I'm at EuroPCR with Dr. Danny Deaver. Rabin Medical Center, Israel, and Washington Hospital Center, DC, came together for a study on using TAVI to treat failure of surgically implanted prosthetic valves. Now, I talked to Dr. Cribier about an hour or two ago, so I wanted to just say this is one of my favorite topics today, obviously. You presented here the late-breaking results of a great clinical trial. Why were you studying it first off, TAVI in these patients with synthetic valves?
Well, first of all, there is a significant amount of patients there is a big clinical need for that. Surgical bioprosthetic valves are being implanted more and more in the last decade, and these valves have limited durability. They are expected to fail after a decade, 2 decades the most. And these people are becoming old. They have a lot of comorbidities, and it will be a second operation if the valve fails.
So high-risk population.
Correct.
So you're using TAVI to try and help these patients. TAVI in Europe, TAVR in the United States. How many patients were you looking at?
Well, we have collected, it's a registry. It's a global, we call it the Global Valve-in-Valve Registry. It was initiated in December 2010, and since then we collected 420 cases around the world, mostly in Europe, but also in North America, in Canada, in Australia, New Zealand, and in the Middle East. And it's getting progress. And this group of patients, and they are very, very sick patients, most of them had no option. And they had TAVI, or TAVR, inside a degenerated bioprosthetic valve, which is not exactly the same procedure that we do in a native valve.
Right.
It has, first of all, we do not have data on that procedure. We had only several case reports and case series about that. So we wanted to know what is the efficacy, what is the safety of the procedure, what is the limitation of the procedure. And I think we got some data already about that from the registry.
I mean, when Dr. Cribier first started TAVI years ago, the one thing that he really looked at was these are high-risk, inoperable patients. You've got the same kind of, even a more difficult group, if anything. So what did you find using this valve-in-valve approach?
First of all, we were very, very happy to see that for such a sick group of patients, the 30-day outcome of that sick group of patients is that 87% of them went to New York Heart Association class 1 or 2. This is really surprising. And also the survival, or I could say the opposite, the death rate, was not so high as we could expect for these sick patients.
For a very high-risk group, right?
And when we divide the patients according to the mechanism of failure of the valves, because this is not a homogeneous group of patients. There are patients that have regurgitation of the valve, patients with a stenotic valve. We can say that all groups did really well. The regurgitation group, their mortality rate was only 4% in 30 days. Only 4%. This is one of the most amazing results for TAVR cohort that you could find. And also the 1-year survival rates and the clinical results are quite outstanding, I would say.
So where do we go from here? Do we need more data, or are you ready to say, if you have a patient like this, let's try it if you're really good with TAVR?
First, these are the good results. We have some limitations of the technique that we saw already. We have some safety signals that we saw. We had 8 cases of ostial left main obstruction after the procedure. This is much higher than in native TAVI procedures. We had many cases with malposition of the TAVR valve and a need for a second TAVR valve. So it will be the surgical valve, first TAVR valve, and the second TAVR valve. And we had another efficacy limitation of the technique, which is high residual gradient after the procedure. So especially in specific situations. So we are collecting the data and we learn from that. What are the situations that the technique is good at? What are the situations that maybe we should wait for another devices that probably will come in several years? And we are now at the stage that we are keep collecting the data and learn more and more from each time we do the analysis.
I think it's really a positive study overall, and I like the idea that we have a new option for a group of people who have been very, very sick. And if you want to read more about this, we will have an article regarding the presentation here at EuroPCR in CardioSource Interventional News. I'm Rick McGuire.